anyone else who joins the room. Okay?
Yeah, no problem, will do.
Perfect. Okay, so it is my great pleasure to introduce you all to our concurrent session on hearing from nurse leaders and seasoned nurse practitioners about their experiences and lessons learned from COVID-19. So the objectives for this session are to enable an understanding of how NPs have made notable contributions to care across sectors during COVID-19, to demonstrate how this contribution can advance NP scope of practice in the future, to identify alignment with key recommendations of the NP Task Force Vision for Tomorrow. So I would like to introduce you to Suzanne Robichaud. Ms. Robichaud holds the position of Vice President of Clinical Programs and Chief Nursing Officer at Hospital Monfort since July 2016. She has over 25 years of experience in management in a clinical setting, including 5 years as Vice President of Primary Health Care at Vital Health Network, located in New Brunswick. She was responsible for 6 hospitals, 3 community health centers, and 7 health centers, and managed a budget of over $100 million during her mandate there. Ms. Robichaud's career has evolved within minority Francophone settings, both in New Brunswick and Eastern Ontario. Her career has spanned direct nursing practice, management in acute care, and telehealth and research roles. Over the course of her career, Ms. Robichaud has given many presentations and trainings, both nationally and internationally, and sat on several boards of directors and associations. She was the recipient of the Award of Merit from the Nurses Association of New Brunswick for her contribution to innovative health programs, leadership, and teamwork. I would also like to introduce you all to Aric Rankin. Aric Rankin is a settler Canadian who lives and works in Hamilton, Ontario, the traditional territory of Anishinaabe and Haudenosaunee peoples. Aric is a primary healthcare nurse practitioner and works in this capacity at dehs Aboriginal Health Center in Hamilton, Ontario. Aric is currently pursuing a PhD in nursing with a focus on Indigenous health and health equity. In Aric's spare time, he is a volunteer with the Canadian Medical Assistance Teams and outgoing board member of the Registered Nurses Association of Ontario. Aric is married to a beautiful wife and is a proud father of 4 adorable children. And Aric, I do apologize if there were any mispronunciations. Please correct me during your time speaking, okay? Perfect. So without further ado, we'll continue on to their session. And thank you both so much for being here with us today. I've just asked to unmute you, Suzanne. You're just on mute there.
There you go. Are you hearing me well?
We are, yes, we're good.
Perfect. So thank you for the nice introduction. And it's always a pleasure and an honor for me to be here to present at the RNAO session. For me, I thought today that I'll give you a little presentation to talk about experience and lessons learned from COVID-19. Are you going to help me, Katrine?
I will absolutely. I'll advance your slides.
Perfect. Thank you so much. So first I'll talk about the hospital, a little bit about the hospital, then the nurse practitioner. Then I'll give you a little video of our nurse practitioner experience during the COVID-19, and then a little conclusion. So first, Monfort Hospital is a Francophone academic hospital affiliated with University of Ottawa. We provide bilingual services as part of our hospital system. We serve 1.2 million people. We receive accreditation with exemplary standing with Accreditation Canada. And we've been designed as BPSO by RNAO. And we are one of the 30 best employer at the National Capital Region in 2015-2017. Next slide. I thought I'd give you a little bit of stats just to appreciate the size of the hospital. So we're over 1,800 employees. We have 7 nurse practitioners. We have 289 acute beds. We have 7,500 intervention surgery. We have 3,200 delivery in family birth center a year. And we have 57,000 emergency room visit per year. And we have 3 research chair. Next slide. Our journey as Best Spotlight organization started in 2012. We're happy to say that we have 10 best practice guidelines implemented at this moment. And we use an interprofessional approach in implementing and developing and evaluating our guidelines. And these are the 10 guidelines that we have so far. Next slide. I just put that slide to show that we're really working hard to have the 4 model of BPSO. We want to be, we're an organized hospital already, and we're just being designated to be host for Francophone for the region and the province. And we're also having an OHT BPSO program. So we're really looking forward to implement all these different category of BPSO model. Next slide. So we're in the process of becoming OHT BPSO, and these are our very important partners. Next slide. So at Monfort Hospital, we are very proud to integrate nurse practitioner into our model of care for over 15 years. Next slide. And we have our nurse practitioner works in emergency department, inpatient orthogeriatric, outpatient clinics, inpatient mental health, community outreach mental health, and inpatient rehabilitation. And next slide. These are the reason that we integrate nurse practitioners. We firmly believe that the increased access, timely care for Ontarians, the enhanced coordination and continuum of care for both in the hospital and outside the hospital, they improve the delivery of patient-centered care and reduce fragmentation of client experience. They enhance quality and safety of our patient care. They improve the patient flow through the system and increase hospital efficiency in the wait time in emergency, decreasing the length of stay and decreasing the readmission rate. They also optimize utilization of human resources, and they enhance interprofessional collaboration. So we firmly believe that Ontario healthcare system resources are more effectively and efficiency. Next slide. So I wanted to share with you our experience and lessons learned from COVID-19 from point of view of 3 different nurse practitioners. One in the emergency department, France Farley, one from a mental health community outreach, Anne Hilarog, and one from the inpatient rehabilitation, Vanessa Heller. So I'll have a small video. The first one is France, who will speak first. She's not only a full-time nurse, but also she works in teaching and mentoring nurse practitioner at University of Ottawa. So if you can put the first video.
Monfort, mainly treating CTAS 3, 4, and 5. About how we deliver emergency services. Thankfully, the demand for services never exceeded our capacity to deliver care to our patients. Upon reflection, I do realize nurse practitioner can safely treat large portion of patients presenting to the emergency department. NPs can make major and very effective contribution to patient care both during period of crisis and non-crisis. This is certainly true across the province. I do take every opportunity to mentor future nurse practitioner so that when opportunities present themselves, practitioner will have the skills needed for their work. Increasing nurse practitioner position within teaching hospital by directly funding permanent position and incentivizing preceptor will help build sustainable supply of practitioner for this and future challenges we may face. Nurse practitioners still struggle with regularity barrier with respect to ordering diagnostic tests such as CT scan. Another area that remains a challenge is access and continuity of care for patients via their insurance providers, who often fail to recognize nurse practitioner services as analogous to physician counterparts. Certainly, when facing a crisis, such as a COVID-19, barriers such as these duplicate work, waste valuable human resource when they are most precious. Supporting and incentivizing nurse practitioner in the hospital who integrate nurse practitioner and addressing ongoing barrier to practice are valuable lesson from this crisis.
Next slide, please. Catherine, you're doing a great job.
Good.
As an institution, we encourage and applaud effort that will give our nurse practitioner more autonomous, and we want them to be more efficient in their services. And this is especially important in crisis when we may not be able to afford inefficiencies. So there's a direct link with the TESS recommendation number 1, increasing the supply of nurse practitioner. Recommendation number 7, optimizing access to continuum of care. And finally, recommendation number 1, with working with partnership with academic institutions. So now our next video that we have is Aric is also dedicated mentor for nurse practitioner student at the University of Ottawa. She provides valuable clinical experience in the area of addiction medicine and prescription and controlled drug and substance. So you can go ahead and play the video.
Hi, my name is Daniela Rock. I've been an RN since 2002 and a nurse practitioner since 2007. I work in a community outreach role within the mental health portfolio, providing primary care services to people in retirement homes and to patients struggling with chronic homelessness, addictions, and mental health illnesses. The pandemic has required that I shift a significant portion of my practice to virtual and telemedicine modalities where possible. I also provided services intermittently to our COVID assessment and treatment centers. My role involves supporting patients in non-traditional settings where inequitable access to healthcare has been a long-standing issue. By being creative, I managed to reach my patients during this crisis. Being connected to the resources of an academic hospital gives me access to specialist consultations, the latest developments and learning opportunities for my own continued professional development. This is especially important during the pandemic when the science and knowledge are rapidly evolving, and being connected to the latest information has enormous impact on quality of care. Our model of community outreach linked to an academic hospital is an excellent opportunity to mentor future nurse practitioners. Our hope is that they will be prepared to offer high quality services to historically marginalized communities by accessing state-of-the-art resources during their training and beyond. Thank you.
So our next slide, please. So Aric's role in this project aimed to serve risk and marginalized communities. This model aimed to support and prevent emergency department and hospitalization. Using a nurse practitioner this way can scale out and serve various community needs across the province. One of our big ongoing concern in marginalized population in particular will struggle to have access to routine and preventive service during the crisis. Having an innovative and well-supported model has allowed us to pivot quickly. And it has a direct link with recommendation number 4.4, enable accessible continuing of care of education and professional development. Recommendation number 2, scaling up and scaling out nurse practitioner. And finally, recommendation number 2.2, promoting systemic planning process for role development and implementation. Now, our last but not least video is Vanessa Hiller. She will speak next. She is a dedicated mentor to nurse practitioner student from both University of Ottawa and University of Toronto. We are proud to say that she was one of the first nurses in a few in the province who have acted as a most responsible provider for hospitalization patients.
My name is Vanessa Heller. I've been an RN since 2007 and a nurse practitioner since 2011. I work on an inpatient rehabilitation unit providing consultations and in an admissionist role. Being a nurse practitioner in the middle of a pandemic has certainly been a steep learning curve. I've had to reconsider my diagnostic approach and how I provide patient and family-centered care. I'm fortunate to work at an institution that has a long history of investing in nurse practitioners. Several years ago, Monfort was at the forefront of piloting nurse practitioners as MRPs for hospitalized subacute patients. As a nurse practitioner MRP, I honed the competence and confidence to work in this role. We were unable to sustain the model due to operational and logistical challenges. Sadly, the pilot was terminated in 2018. However, lessons learned and skills developed through this pilot have been extremely useful during the pandemic. Our inpatient rehab unit's hospitalists were suddenly all required to self-isolate, making me the only practitioner available to work in person on this unit for a period of time. Having policies and procedures, as well as the organizational memory, made for a seamless transition to the nurse practitioner managing care for these patients. Having experience in this role made for competent and confident high-quality care on my part. I think one of the key lessons that I have learned from this pandemic is that nurse practitioners throughout the province are an underutilized resource. The current environment means that highly skilled and highly educated professionals are often being sidelined. Very few organizations in Ontario have invested in nurse practitioners the way that Monfort has. I'm thrilled to see that the task force recommendations look to address optimizing NP scope, increasing positions that will fill the need for preceptors, fund NP-led research, and incentivize organizations to integrate nurse practitioners into their model of care.
So next slide, please. So we at Monfort Hospital understand that, and we have proven that nurse practitioners are capable of attending and the most responsible provider role. The recommendation highlight team-based funding model, which would be helpful going forward. There is a lack of congruent amount of funding model for different professionals, which is a scenario where team-based approach is important. It is in certain scenario where you have nurse practitioner working as a traditional physician lead role or a most responsible provider. Collaboration for on-call or after-hour services become extremely challenging to negotiate without a framework to go. Creating capacity for time of crisis, such as this, require us to plan our non-crisis model to be scaled and address structural barrier to progress. And there's a direct link with recommendation number 2, optimizing the utilization of nurses practitioners, and recommendation number 2, which is scaling interdisciplinary team-based funding model. Next slide, please. In conclusion, nurse practitioners are very valuable for the Monfort Hospital team. Nurse practitioners are playing a key role in the pandemic response, and in partnership with RNAO, Hospital Monfort is committed to continue to support and foster the contribution of our nurse practitioner in our healthcare system. Next slide, please. I am very proud of all our nurse practitioners, and I thank them for helping me with this presentation. And next slide is all their emails. Feel free if you want to contact them. They give me the permission to share that with you today. This was my presentation. Thank you.
Thank you so much, Suzanne. We really do appreciate you taking the time to connect with all of the NPs at Hospital Monfort, to share their experiences through a video platform, and for us to be able to hear from them directly what went well, what they learned, and what they need to think about for the future of their role given the pandemic. And now we will turn over to Aric, who brings a bit of a different perspective working with Indigenous communities during COVID and beyond, of course. So Aric, we would love to hear any synergies that you heard from Suzanne, and as well a bit about your own practice and lessons learned during COVID.
Excellent, thank you. Can you hear me okay?
Yes.
Perfect. Thank you very much. Thanks for the opportunity to RNAO, to all those that put together the symposium, and thanks for my colleague Maria. Very definitely some things that I can resonate with for sure. For those that don't know, my name is Aric Rankin. I'm a nurse practitioner in primary healthcare, and I work at dehs Aboriginal Health Center. You did pretty good there, Catherine, with the introduction. And that's in Hamilton, Ontario. Dehs in the Cayuga language means a place where we care for each other amongst ourselves. And this is a healthcare center that provides holistic and culturally centered care to those both rural as well as Indigenous community members, both in the Hamilton, Brantford, as well as the Niagara regions. Dehs, the primary care clinic, is only a small part of what the services that are provided at Dehs. We collaborate with traditional healing department, mental health and addiction services, health promotions, housing and outreach services, as well as an impressive Indigenous patient navigator service that helps to bridge those individuals that wish to access biomedical or Western medicine. And then also to help address the broader systemic issues such as systemic racism. The primary care clinic as a shared care model, meaning that we have nurse practitioners. I'm one of 5, 2 in Hamilton, 2 in Brantford. We have one that is recently hired with our housing and outreach services, and she goes between Brantford and Hamilton offices. Soon, hopefully, we'll be providing primary care services in the Niagara region as well. For now, we offer patient navigation services and mental health services in those areas. We also have fantastic physician colleagues that we work alongside with, as well as, of course, our medical admin staff that allow for the roof to stay above our heads and to allow us to work as a team as most efficiently as we possibly can. So I was asked to talk about experiences during COVID, and more particularly about what I've learned and what our organization has learned and how we've pivoted our services given these very trying times. First, I'd like to start off with a bit of some background, more specifically to the Indigenous population. I myself do not identify as Indigenous. I am a settler Canadian, and I do work on the traditional territories of the Haudenosaunee and Anishinaabe peoples. I take great pride in working with this community, and I am an ally working alongside Indigenous community members and for the Indigenous communities that I serve. According to the United Nations, Indigenous populations have a relatively high risk for socioeconomic marginalization, which makes that particular population vulnerable. I don't think this is new information for many people, but along with that comes a great deal and an amazing amount of resiliency. Also, according to the United Nations, because of some of the traditional lifestyle, this can put Indigenous communities at risk, but at the same time also contribute to that resiliency. Some of those components, it doesn't matter whether it's urban or Indigenous community members you're talking to, might be large gatherings of events honoring harvests, moon ceremonies, or even the component of providing to their family members, including multi-generational housing and honoring elders and caring for elderly family members. As I mentioned, some of these are risk factors, but in many cases, these are also the reasons why we've seen some of the more locally here in the Hamilton area, the numbers quite a bit lower with that compared to the general Canadian population. More specifically to First Nation communities, or reserves, as some may know, the percentage of First Nations living in reserves reported positive COVID-19 outbreaks are about 1/2 the rate of the Canadian population, and that COVID-19 case fatality rates for First Nation individuals living in reserves are about 1/5 the fatality rate of that of the Canadian population. More than 61% of those tested positive for COVID-19 have completely recovered. More specifically, we've probably heard in the news that Nunavut Premier Joe Saginaw called for a lockdown as a result of 70 positive cases of COVID in Nunavut. And so we can see although they had been successful in keeping COVID out of the territory for quite some time, how quickly COVID can impact communities. More specifically to the area community that I provide services to here in the Hamilton and Brantford areas, we've only had one positive case of COVID that we know of patients, and about 100 that have self-isolated with probable cases. That likely has increased a bit. This is from last week, but those have all tested negative. So as I mentioned, the Indigenous communities, Indigenous peoples are seeking their own solutions and ways to manage this pandemic, specifically Six Nations, who is very close to our area here. We worked very closely with, both for PPE and attaining PPE materials, but also in working with community members, because some of their community members will come for services in Brantford or Hamilton area. They're taking action by utilizing both traditional knowledge as well as science that's available. Also using different practices such as voluntary isolation and sealing their territories with very stringent screening techniques and ensuring that their populations are safe. Also utilizing and honoring their own languages, and whether that's through general information and communicating about COVID and the risks that it portrays and can portray, not waiting for governments to be able to provide those fundings, in fact, using fundings from their own purse to be able to make sure that that information is available in their own languages. Certainly the government has contributed in many ways, providing not subsidies, but funding for Indigenous organizations as well as rural communities to be able to fight COVID. And that is what I've been told from community members and leadership that is incredibly grateful, but it needs to come faster. When it comes down to, and talking and preparing for this talk, I talked to our CEO, Constance McKnight, about her thoughts about the current numbers in the Hamilton area. And she had mentioned that stigmatization as well as discrimination and poverty have kept patients away from gyms or going out to restaurants, or even in some cases accessing healthcare services, which of course are unfortunate in the reality of the current situation. But it's also the value of family and caring for those elders that has contributed to the lower rate of COVID. As far as Dehs Desne and how we've pivoted during these COVID times, we've made quite a few changes, some of which have been NP-led and driven, but I can't take, and I don't think the NPs can really take credit. It's really been a team effort, both working with our organization as well as community members. And so that's initially when this had all started, we went to a team 1, team 2 strategy where reception staff, and this is speaking specifically to primary care, most of the other services were able to work from home. But primary care, we didn't stop. We're still seeing patients. Team 1 and team 2, there was always a clinician, whether physician or nurse practitioner. More predominantly be a nurse practitioner because our roles are permanent or are full-time, whereas the physicians are part-time. And then also a reception team member or a administrative staff. And so then we would rotate every week. Screening was immediately done by phone and also at the front door, as well as temperature checks both for patients as well as every staff member. We had a creation in which, as I'm sure some of you, some of your colleagues have probably been on the planning to have more virtual services available. This is definitely put this onto the highway as far as getting things done. So now we have moved forward with telehealth, which PSS is the electronic medical record that we use, and we now offer virtual services, which I can tell for some of the elderly patients and patients with multiple health concerns and physical immobilities are extremely grateful for that, and for that we hope to continue with that even after this pandemic and when we have conquered it. Also, we've created a family room, which has also been kind of moved forward. This family room is for those well child visits and infant or child assessments, large enough to house an entire family. We've also moved from individual assessments in each clinician's room to have one room that is used and then cleaned, and also scheduling time in between to ensure that it's fully cleaned. We also have staff that comes in to do a full clean of the entire primary care clinic 2 times a day, at lunch and then also into the evening. As my previous colleague at the lunchtime presentation mentioned, we've, as a clinician, have had to pivot as far as our diagnostic skills in using virtual platforms as well as teleconsult in order to be able to diagnose and identify treatments. Ordering diagnostic tests, as we've talked about before, as far as insurance companies and other barriers that may exist, this COVID pandemic has also presented some of those barriers. For example, much needed spirometry tests that have been canceled or postponed, many referrals that have also been postponed, and even surgeries. And so for that matter, some of these most frail and most vulnerable population of our client population have been in extreme risk. And for that, we haven't closed down, and in fact are meeting with those individuals either virtually, or even now we've been doing some home visits with additional parameters. We've started and pivoted with a few of our clinics. We have a Breathe Easier clinic, which helps with COPD, asthma, and other respiratory issues, and also a hypertension management program, which we've now got a program for portable blood pressure monitors that we mail out to members of the community, and so we can monitor their blood pressure at home so they don't have to go to a local store to be able to check. And finally, it's, as I mentioned, it's been a team effort. Health Promotions Department did health checkups, phone calls with every client that we had at each of the sites, which is phenomenal and an amazing amount of work. Our traditional healing group has moved completely virtual, which, as you can imagine, from a culture that really celebrates and prides itself with interpersonal connection and of the spirit, both that in-person experience. This has been a tremendous pivot to move to a virtual platform to be able to provide some of those teachings, some of those connections with community members. And members have been pretty responsive to it. They understand the risks and that this is the best that can be done at this point in time. And then finally, our addictions and mental health services. This has been a tremendous amount of pressure on my colleagues. We have to be careful about vicarious trauma. Those individuals that are either self-identify as Indigenous and have experienced some of the significant social determinants and Indigenous social determinants of health that are experienced on a day-to-day basis, as I mentioned, including systemic racism. And this has placed a considerable amount on the counselors and elders that are providing those connections and services. And some of the funds that we've received have helped to broaden those services, but also recruitment has been a difficult task. In fact, our most recent NP was hired via Zoom. We can go to the next slide. And so when it comes down to it, we're actually looking at the recommendations from the task force. As being a member of the task force and really advocating for these, whichever recommendation you choose, COVID has certainly presented more barriers in achieving these, but at the same time, I think it's highlighted in many ways more reasons why we need to move forward with these recommendations. And more specifically, the increased supply for NPs across all settings, including Indigenous health. We've been very fortunate to hire a nurse practitioner. However, it's still not enough. We have a wait list for Indigenous community members that either are homeless or at risk for homelessness, and in many cases do not have access to a steady primary care provider. Many are going to walk-in clinics, urgent cares, or emergency departments. So that's needed, and that's particularly for a vulnerable population, but at the same time, when, as I mentioned, it's so resilient. We need to optimize the utilization of the NP scope of practice, absolutely, without a doubt, and we need to also expand that scope of practice for the additional parameters that allow us to be able to fully assess, fully diagnose, and utilize diagnostics to be able to provide the best possible care for the clients and their families. We also need to, as far as harmonization and looking at compensation, I'm proud to say that the dehs has always followed the government funding as far as pay equity for NPs in primary care. In fact, they truly honor the NP role and see it as a very valuable role and team member in the organization. And then the last recommendation, I think we can go to the next slide. The last recommendation I think that's most important is how we look at optimizing the continuity of care with insurance providers and payers. I've shared in the chat box there that the Hamilton support, I'm not sure what the purse is called, but it's basically for support for orthopedics shoes. Many of these policies, both municipal-wise as well as in some cases national-wide with these insurance providers, are completely dated with much more physician-centric vocabulary. And it needs to change, and I'm so happy to see that this is a priority with the task force, and to see that it's resonated with so many people in the chat box during that talk this morning. A colleague had mentioned earlier about how this puts us in a situation where the patients can question the trust in us as to being able to order tests and be able to completely manage without the assistance of the physician, when many of the clients that are rostered to myself rarely have to see a physician and are completely managed under the auspice of a very competent NP team. And I think those are all the recommendations that I'll touch by in this presentation, but I'll just leave with that we need to move forward in ways that support both the mental, the emotional, the spiritual, and ultimately the physical health of each of the clients that we care for and their families. And the task force certainly is one way that, and those recommendations is one way that we can certainly do that. But we need to keep an open mind, and we need to consider the world views and our own personal experiences as we move along the path with the clients and families that we care for. Thank you.
Thank you so much, Aric. Again, we really appreciate you bringing your unique perspective, one that is, I'm sure, no doubt, a bit different from where Suzanne is coming from an acute care background, but surely there are some synergies in the areas that you two are each working in, and some similarities in terms of what is needed for NPs moving forward into the future, as well as lessons learned. I think there absolutely are some commonalities between the two of you, and it's great to see what you have each learned in your own individual sectors, kind of side by side. So with a couple of minutes we have left, we'd like to open it up to the participants right before we get into the evaluation. Are there any questions participants have that they'd like to pose to Aric and/or Suzanne?
Hi. Of course,
Hello.
good afternoon.
Yeah.
Thank you for this great presentation. Aric, thank you. You identified yourself as a plain old Canadian. And I just wondered what you meant by that.
I had to find my unmute button. I'm sorry. So I identified myself as a settler Canadian.
Okay, I didn't hear the settler part.
Yes. So settler Canadian. My family's heritage is of Welsh, Scottish, and Irish descent.
I didn't hear the settler part. I heard something else, Canadian. So thank you.
No problem.
Any other questions for Aric or Suzanne, or any reactions from Aric or Suzanne hearing one another's presentations? Was there anything that surprised you about each other's presentations? Okay, so we will move on then to the evaluation polls, and we'll ask you to answer the questions that pop up on your screen. And then we will ask you to go back to our main event session, which we will post the Zoom information for once you have finished the poll. Thank you guys so much. Okay, everyone, so I have posted the link back to the main session. If you want to copy and paste it, that will take you back. Or if you want to go back to your email, you should have received the link via email that you can quickly click on, and make sure you enter the meeting ID as well as passcode to join us for our 2:15 to 2:30 session. So we'll see you all there. And again, thank you so much, Suzanne and Aric. Really appreciate your presentations.
No problem, Catherine. Looks like Sarah might have asked a question here about moving into the second wave.
Yes, by all means, feel free to answer quickly.
Yep, so just very quickly, Sarah's asked, as we inch towards the second wave, what are the priorities for the community? I think at this point, we've learned a lot from the first wave and how to pivot and move forward. I think that the priorities for the second wave are going to be, I think, mental health and addictions, and continuing to connect with individuals as best as we can. I think that as primary care providers, I think, whether working with marginalized communities or the greater Canadian population, I think that kind of spans right across. But certainly those with risk factors can be at higher risk. So I think that's, if they're going to say one thing, it would be that if you know of any of your patients that may be at higher risk, connecting with them more often is certainly going to be a priority. Thanks again, everybody. I'll see you in the big group.